Hi, everybody, and welcome to the latest webinar in our series specifically for social prescribing link workers or those that are in similar roles. Today, we are going to be focusing on supporting people with long-term conditions. But before we get into the sort of meat of the session, if you like, I'm just going to take us through a little bit of housekeeping. So, Audrey, if we could just go to the next slide, please. Thank you. So we are going to be recording this webinar and we will send the recording and all of the slides to anybody that has signed up to join this webinar today. We'll also have them on the website so that you can share them with any colleagues that you think might be interested in this webinar as well. We're going to be using the Q&A function in Zoom today, which is at the bottom of your screen. So please do use the chat function to introduce yourself, but the Q&A function to ask any questions to our speakers. We will bring these to the speakers right at the very end of all of the presentations. Towards the end of the webinar. In the chat, that's also the place to raise if you've got any technical issues. We've got members of the NASP team supporting with this webinar today, and they will be able to support you with any issues that you might be having. It's great to see you all introducing yourselves in the chat. And also just to note that closed captions are available. So please, if you need these, you can turn these on again in that bottom bar that you will see in your screen. Great. If we can go to the next slide, please. Thank you. So yes, welcome to this webinar. I'll be chairing today. So my name is Monica Bolton. I'm the Strategic Lead for Healthcare Integration and Neighbourhood Health here at NASP. We are going to be hearing from lots of different speakers today. So we've got Jenny and Jack from the Richmond Group of Charities, Sandra Mitchell-Phillips and Thomas Lovedawn from Ways to Wellness, and Bridget Mangan, who is a link worker from Five Valleys Medical Practice. We've chosen to focus this webinar on long-term conditions today because both the evidence for social prescribing and long-term conditions is really growing, but we're also seeing a real growth in specific social prescribing projects that are supporting those with long-term conditions. But even those that perhaps aren't specifically set up to support people with those conditions, link workers are coming into contact with people who are often suffering with multiple long-term conditions, which isn't perhaps a surprise, as there are millions of people in the UK that are living with at least one long-term condition. And that is, according to the Health Foundation, set to increase by 37% by 2040. And supporting people to manage these conditions can really support people to have a better quality of life. And link workers in particular, due to the skill set and the time and the role that you have in health settings, are really in that position to look beyond someone's condition to ensure that what matters to them is really included in any conversation about their overall health and well-being. So it's really great to introduce some of the speakers that we've got today, that we're going to be looking at the importance of engaging with people with lived experience when sort of setting up initiatives, through to measuring the success and how we can help that evidence base to continue to grow, as well as that sort of team around the person kind of approach to this work, specifically working in multidisciplinary team or MDT team setting. So I'm going to leave it there and hand over to our speakers to take the floor. So first, we're going to be hearing from Jenny and Jack, who are from the Richmond Group of Charities. So Jenny joined the Richmond Group of Charities back in January this year as the new programme director for an initiative that's funded by Sport England, their sort of physical activity programme. The We Are Undefeatable programme combines a national behaviour change marketing campaign with influencing policy and engagement work. So everything the programme develops and delivers is really underpinned by lived experience, insight and involvement. We're then going to be hearing from Jack, who lives with asthma and is also a carer. So he really knows the importance of that, of how that right support is so crucial. So through his own experience, he says that he's really come to value the role of community and connection in helping people to feel seen as that whole person, not just condition. So do engage with the speakers by asking any questions in the Q&A function. But for now, I will hand over to Jenny and Jack. Thank you so much for joining us today.
Thanks very much, Monica. I'd forgotten I'd sent that intro. You've done my introduction for me, which is excellent. So yes, we're absolutely thrilled to be here today, and we'll come on to Jat's story a little bit later. But I guess first, just as a bit of an introduction to the We're Undefeatable programme and who we are and what we do. So if we could pop on to the next slide, please, and the next one. Thanks. So launched in 2019, the We're Undefeatable programme has been running for a number of years thanks to our funding from Sport England. It's been established as a behaviour change marketing campaign and system influencing to support those with multiple conditions to be more active. So I guess our USP is that as the Richmond Group of Charities, we're a collaboration of 15 leading health and care charities. So we're working together to support communities. There's a huge amount of understanding and a real breadth of sort of knowledge across different conditions, but also how it can impact people when there are multiple conditions at play. And as Monica mentioned, keeping lived experience really is at the heart of what we do. So today, I guess we're going to set the scene a little bit for this webinar, sort of looking at the national perspective and how the We're Undefeatable programme is bringing lived experience voices and insights to life through our programme. We're going to look briefly at what the data tells us and what we know with a physical activity lens, but this is relevant across sort of all sectors. And then we'll hear from Jat, whose lived experience has helped inform our programme and will provide us with some really valuable insights. And then at the end, we'll look a little bit at what We're Undefeatable can do, hopefully, to help and support in crucial roles such as yours. So firstly, let's have a little look at the data. This isn't going to be new information. Next slide, please. But I wanted to set the scene initially just to look at sort of what the scale of the issue is and why in work like yours and across the health and care sector, programmes like ours can be helpful, and also why all of us really are so needed to support. So the impact on individuals of having long-term health condition or multiple conditions, the cost to the NHS, all sort of key drivers really in why we do what we do, but also what we're looking to change. So on the next slide, through our surveys and data collection, we've got a really broad evidence base now that gives valuable insights into what the key barriers are for people to incorporate activity or movement into their daily lives. And I guess it's key to note here, as we move on to the next slide, that physical pain and other symptoms are the stoppers. So what people feel like they can physically do is stopping them from becoming active or incorporating movement into daily life. And then when we compare that with the data from healthcare professionals, so this is through survey data that we collected a few years ago, we can see that actually there isn't the same, the stats aren't the same. So the level of understanding is different, or what people's sort of assumptions are is different. And I guess the real value and importance of bringing lived experience voices into the room starts to become increasingly obvious, because we can see that what people are telling us is their barrier and what others think are the barriers are different. So on the next slide, what we can see is that crucially, one of the most trusted of sources of advice for physical activity and information is the NHS or other healthcare professionals. So that's where people are going to. And so if we're thinking then actually that the understanding of those that are experiencing barriers and issues and those that are providing the support and advice and guidance is different, then we need to bring those who are most able to influence along to be able to support in the most relatable and valuable way. So the next slide shows us that what we see from data collected through the We're Undefeatable programme is that over 1 in 4 people who have been provided advice from their physical activity professional, their healthcare professional, that they have taken action, they have become more physically active. And so we can also see that nearly half of those people who were provided advice have thought about becoming more physically active, which, as we know, if we're looking at behaviour change through the trans theoretical lens, that actually thinking about taking action, contemplating taking action, is a really big step forward for those with the most complex needs, or those that are furthest from sort of an active lifestyle. And I mentioned it before, but as we go on to the next slide, we're going to think a little bit more about the sort of the lived experience voices being really crucial in this journey that people take. Next slide, please. Thank you. And so lived experience insights really do underpin and are embedded through everything that we develop and deliver in the We're Undefeatable programme. So whether that's through our data dashboard, which we'll talk a little bit more about, or our the quantitative data that we get from our campaign, but actually it's the storytellers and the user-generated content and our lived experience network that give us such valuable insights that help us to understand who we're here for and how we can be most valuable to them. So on the next slide, just wanted to talk a little bit about our lived experience network. So we've recruited a network of people through our charity partners, through the Richmond Group, but also through open recruitment. It's a rolling recruitment, so there's no fixed term or closing date, which helps keep the network fresh and relevant. But they advise they act in an advisory capacity for us as a programme, helping to shape our decisions, helping to develop the work that we deliver and what we do. So there's a number of things there that you can see on the slide, but on the next slide, just some examples of how the Lived Experience Network have been involved in the programme so far. So it's everything from a governance level on our programme board through to storytelling and social media. But we've also had members that have joined us at events or supporting on policy work and webinars, which leads me to hand over to our guest today. So I'm going to hand over to Jat, who's kindly joined us to talk about his experience with the We're Undefeatable programme, but also how he's encouraged others through his experiences as well. So Jat, over to you.
Hi everyone, my name is Jat. I joined the We Are Undefeatable campaign in 2021, so I've been a part of it for a couple of years as a long-term asthma sufferer, and I'm also a carer for my mum who's got a learning disability. And I've spoken about this to friends and colleagues and family members before, but I was diagnosed with asthma when I was around 7 years old, and I think we've come a long way since then as to how we encourage people to deal with long-term conditions and live with them rather than live against them. I was told from a very young age to be very mindful of physical activity. Anything that was going to increase my symptoms or going to affect me in a negative way, I was being told to avoid it at all cost. There's also data that suggests that asthma sufferers are going to be higher sufferers when it comes to hay fever. So a lot of people recently might be suffering with hay fever. And again, I was just being told, don't go outside, don't do anything that's going to be strenuous to you. But as time has gone on, we've been encouraged to be more physical. And I think actually it was during 2021, as we were coming out of COVID, that I discovered the We Are Undefeatable program, which actually helped me to really become more physically involved in my own health, rather than sometimes feeling like I was a bit of a participant as to what was going on with myself and leaving everything to a healthcare professional rather than actually taking some ownership myself. So anything that I've learned with the We Are Undefeatable program, I've actually also incorporated it into my mother's daily routine. So that actually has helped both of us to actually even connect with each other. It was actually 2 years ago, after I'd actually noticed really positive changes from being more physically active by following the We Are Undefeatable program, that I heard about there was a startup of a choir where my mum goes for a daycare centre for adults with learning disabilities. So I became involved in that, and I now run a choir. As an asthma sufferer, singing and breath control and really pushing the capacities of what you can do is something that I was initially advised not to do as well. But I began to do it, and it actually, you don't have to be a world-class singer, but it's just about being able to push yourself and to make sure that you can really understand your condition a lot more than you did before. And I think that's how I would probably advocate for people living with long-term conditions to really explore their condition in a safe way as you can, just to understand it a bit more, because everyone's different. No asthma sufferer is the same as the next person. I've got friends who are asthma sufferers who can do a lot more than I can do, and there are people that can't do as much as I can do. So I think going forward in a holistic way, I think it is important that we don't just look at the symptoms and the condition, we look at the person as a whole and their lifestyle, and to really understand mental health can play a massive part in managing their condition as well. Thank you.
Jack, thanks so much. And I think, yeah, absolutely sort of nail on the head there. It's the holistic view of a person rather than looking at sort of symptoms or a condition. And that's certainly something that, we really advocate for through our policy and lobbying work, but also how we sort of integrate that into the physical activity resources that we provide and the advice and guidance that we would provide to others as well. And so I just wanted to finish on sort of how our resources and guidance are available to help and to support. So if we can just head on to the next slide, please. Thank you. So the words are tiny, but the slides will be shared. So you will have access to the links. But as I mentioned, all of these that we're providing are underpinned by insights and data from our audiences and those with lived experience to give that truly person-centered approach. So from activities and workouts for those looking to get active through to the We're Undefeatable app, which is a free app providing personalised and group sessions. We've also made available absolutely loads of our resources and insights and reports, whether that's wanting to deliver a local We're Undefeatable campaign, which is happening in a few areas now, or just understanding more about our policy work and reports. That's all available through our campaign hub. And then finally, data. So there was a number of charts and graphs at the top of this presentation. But this year we've made our lived experience dashboard freely available, which has got 7 years worth of survey data, which is available for free. So it can be filtered and interrogated for your needs, for what you might want to find out about particular demographics, particular groups. And we think it's a really valuable resource for those looking to understand more about those with long-term conditions and multiple conditions and how to support to overcome barriers faced. So all there available for those who might want to take a further look. Thank you so much for having us today. Thanks again to Jack for speaking and bringing his insights. It's always really helpful to hear from those who are experiencing what we're talking about alongside all the sort of the policy and resources that goes along with it. So that's it from us. Happy to take any questions. And yeah, please do take a look at the resources if you think they might be useful to you. Thank you so much.
Thank you to both of you. That was absolutely fantastic. And thank you for sharing all of those resources. We'll make sure that those links are live in the slides that we send out after the session so that you can go, and lots of bedtime reading you've given us there, Jenny and Jat. And yeah, Jat, thank you so much for sharing your story and for so eloquently talking about the importance of treating individuals exactly as that, as individuals, and the importance of taking that person-centered approach, which is so much the bedrock of exactly what social prescribing link workers are doing, and therefore perfectly positioned to be ensuring that the support for people living with some of these conditions is really tailored to that individual need. So really appreciate you very much bringing that to life. And Jenny, the amount of it's by no means tokenistic what you're doing with individuals with lived experience. It is totally embedded across all of your programme, and that is really, really wonderful to see, and lots that I'm sure many people in this webinar can learn from. So thank you. And yes, please do put any questions that you've got for Jenny and Jat into the Q&A function, and we'll come to those at the end. But for now, we're going to pass over to the Ways to Wellness team. So firstly, we'll be hearing from Sandra and Thomas. Sandra is an experienced chief executive who has got strong change management background along with extensive experience in strategic financial planning and performance management. Sandra has worked at senior levels both in the voluntary sector and in the NHS and has considerable experience in working with a wide range of stakeholders. So we are looking forward to tapping into your brain today, Charlotte. And then Thomas, thank you so much again for joining us. He is a specialist social prescribing team lead for the Waiting Well project at Ways to Wellness. He is a qualified counsellor and previously worked supporting autistic adults towards employment. Thomas also has a toddler, so I'm sure is incredibly busy in and around his professional life. So thank you to you both, and over to you.
Well, thank you very much for inviting us to be part of this webinar. So Thomas and I are going to do a little bit of a double hander here. So while I'll talk about ways to wellness and our association with long-term conditions, Thomas, who's one of our specialist link worker team leaders, will be able to talk about the impact on the individual. So first of all, to give you a little bit of a background of ways to wellness and why we are seen as a little bit of an expert, I think, on long-term conditions. If we could just move to the next slide, please. So we were created in 2015, and we were created specifically to test the impact of link workers on the system, so on the NHS. We decided to look at particularly areas where there are high deprivation, where we know there are a lot of health inequalities. And we specifically looked at long-term conditions. And you might ask, why did we look at long-term conditions as our first project? You'll have seen some of the data before in the previous presentation, but where we came from was 70% of the NHS budget is spent on the diagnosis, the treatment, and the management of long-term conditions. And what we were hearing from our GP colleagues was actually these were the patients that were presenting far more often to GP surgeries with having a condition that they just felt unable to cope with and unable to manage by themselves. Because we were doing a prototype and testing and collecting data type of program, we needed to be really clear about the type of conditions we were going to look at and a specific age range. So the age range that we started with was 40 to 75. And when I started with Ways to Wellness, I did question, well, why 40? And the view was 40 is the age where you need to start, your long-term condition is likely to materialize, and that's the age you need to start being active in terms of its management. That was news to me because I'd always been told that life begins at 40, not that old age starts at 40. So I found that a bit difficult to manage. If we could go on to the next slide. This will show you the conditions that we decided to look at. So again, this is not the whole range of long-term conditions, and you will all know better than me that actually people have multiple conditions. They rarely just have one. There's often a number of complex needs within those health conditions, and there's mental health that often comes alongside these conditions. But because this is a test and learn program, we needed to be clear what we were monitoring and what we were looking for. So we were very clear in terms of these long-term conditions. As part of the test and monitoring of the program, what we wanted to do was to demonstrate the impact that a link worker, non-medical intervention with a link worker, could have an impact not only on people's health, but also on the system, in particular in secondary care. So we were very lucky that what we were able to do is to have a control cohort. So in terms of the numbers that we were talking about, we were looking at working with around 10,000 individuals with a long-term condition within that specific age range, and had a control group that was of the same age range with the same range of long-term conditions. And we monitored one against the other over a period of 5 to 6 years to see actually what is the impact of a link worker, because there were no other differences between the interventions in these two groups. The only difference was a link worker was actively working with the patients in group 1, and there was no link worker in group 2. Remember, this is long before the R's rules were rolled out into primary care. So while there was a lot of acknowledgement that link working has been going on for quite some time. If you look back, even over history, there has always been charities, there's been organizations who supported people who have conditions. So in some respects, this isn't anything new. It was called social prescribing, they were called link workers. But the anecdotal data was there, but what we didn't have was a lot of the hard evidence that says this works. One of the key differences between the program that we were testing was about a longer term intervention. We were looking to change people's mindsets. So if you could work with somebody at the age of 40 and then work through their life span, would you be able to change their mindset in terms of how they manage their long-term condition, and what impact would that have? So we measured this in two ways. If we could go on to the next slide, please. This is called the Wellbeing Star. Now, I'm not going to go into it too much because Thomas will cover it. He uses this on a regular basis, so we'll be able to answer all of the questions that you have on it. But basically, it allows us to measure people's progress over a certain number of areas. And it also acts as a little bit of a guideline between the link worker and the patient to ensure that all of these areas have been covered as part of the conversation. As I say, Thomas will go into more detail on that. If we can go to the next slide. So this is quite interesting. This is the secondary care. So this, again, remember, this is just the impact of a link worker working with people with long-term conditions. So the blue line at the bottom, it's not very clear. Sorry, these slides are quite small. That's the Ways to Wellness cohort, and the orange line is the control cohort. So what you can see is after year 3, and what we recognise is it takes time to establish programs and to start collecting the data and seeing what the data is telling you. Both cohorts helpfully use the same secondary care provider. So what we were able to see is you can see that divergence between the cost. It's the spend per person. So we're looking at really at a population level between the Ways to Wellness cohort, so that's the link worker, the social prescriber intervention, and the cohort where there's no other intervention. It's just effectively business as usual. And you can see towards the end there that there's actually quite a significant gap in between the control cohort and the Ways to Wellness cohort. So then looking at actually what did that translate to? If we can move to the next slide. So what we were able to calculate, and we used our colleagues in NEXT, which is the data collection and commissioning service, is that there was a saving within secondary care of 4.6 million over 5 years. And this saving is attributed to the link worker, the intervention by the link worker. So that's quite significant. Now, we measured that over 5 years. In reality, we hit COVID at that point, and as you know, everything went a little bit skew with at that point. So the data after that was a little bit more problematic to kind of track along with this same data. If we move to the next slide, what we weren't able to do at the time was get access to the primary care data. So what we had wanted to be able to prove is that the impact of having a link work and the non-medical intervention with a GP surgery, what did that do in terms of appointments? We couldn't get access to that data, and I think certainly the CCG, as it was then, didn't have access to that data either. So we did a survey. So please take this figure with just a little bit of a note of caution. This is based on survey results of the practices that we worked with, and overall, they felt there was around a 14% reduction in their GP appointments. Now, it's quite difficult to measure that because people will often present with different conditions. So even if somebody has a long-term condition, they might then go and see their GP for some other reasons. So it's quite difficult to measure exactly what the reduction is. But there are lots of reports that were written, national reports, and we have reports on our website which will go into far more detail about the impact of a link worker on people specifically with long-term conditions. I'm going to pass over to Thomas now to tell you a little bit more about how we use the Wellbeing Star to help support people and to measure the progress.
Hello, everyone. My name is Thomas. Thank you, Sandra. Could I have the next slide, please? Thanks. So I'm just going to go through how we use the Wellbeing Star to work with people with long-term conditions, because living with a long-term condition is a lot more than just the physical symptoms, and the system has a tendency to make that become the person's identity. So we really wanted to focus on the whole person, and not just what their challenges are, but what their strengths are, because it's very easy to focus on the things you can't do. People often forget to focus on what they can do. And to help us with that, we use a tool called the Wellbeing Star. This was provided by a company called Triangle, and it measures progress over time. It doesn't just focus on one area, it focuses on 8 different areas of a person's life. Could I have the next slide, please? So here is the star. It looks very pretty on the sheet you give people. It's very colorful. It's very easy to understand. It's got 8 different areas, and each one is ranked from 1 to 5. So I'll go through the areas. So like lifestyle, it looks at what they're eating, if they're sleeping well, are they exercising? Next one is, are they able to look after themselves? Are they struggling in some areas? The next bit is about managing their condition. Are they taking the right medication? Are they engaging with the healthcare providers? Do they know what causes flare-ups? How do they respond to flare-ups? The next area is work volunteering and other activities. So are they in work? Are they doing well in work, or are they struggling? Next is money and finances. So are they in debt? Is that causing anxiety? Are they getting appropriate benefits? Those kind of things. The next one is where they live. This might be, do they like where they live? Is it suitable for their health? The next is their friends and family. So are they socially isolated? And the last one is, are they feeling positive? Are they optimistic about the future? So we work together and we rank these from 1 to 5, with 5 being everything is fantastic. I don't need any help. All the way down to number 1, which is, I know there is a problem. I know I want help, but I have no idea what to do or how to get that help. So if we have a hypothetical patient called Mary, who has COPD and mobility needs, she might highlight where she lives as a number 1, because she's got some stairs, which she finds very difficult to get up and down. She struggles to get in and out of the bath, for example. Can I have the next slide, please? So the Wellbeing Star is very good because it's a collaborative approach. We're working together, looking at the different areas and finding out what's important to the individual and not what I think they need or what we think they need. By looking at these numbers, we can come up with plans of action that we both agree that we're working towards, and it gives us a clear direction of travel. So again, if we think about Mary, our hypothetical patient, she's highlighted where she lives as something which is important to her. Whereas I might have thought she's socially isolated and I might have wanted to focus on that. But because Mary's talking about being anxious at home, we link her up with occupational therapy or adult social care or minor adaptations so that we're working on the things that are important to her. We use the Wellbeing Star every 6 months. So we have 1 at the start, 1 after 6 months, 1 after 6 months, and then at the end. So at the start, Mary's identified where she lives, but then in 6 months, actually, we've got some adaptations in place. She's got a stair lift and a grab rail for the bath. So actually, she's feeling quite good about where she lives now. But now she's identified, actually, she is a bit isolated. So that score for isolation might actually go down because that has become her top priority. So then we can focus on that part of her journey. We can change our focus from one point to another point. Having these set points of data and having these set conversations with the patients actually helps us to build a story of their journey and helps us demonstrate the impact of those things that sometimes are hard to capture through just numbers. This is how the patient is feeling at these particular times. This is the progress they're being made. This is another positive of the star. It highlights how far they've come. Like, when you can bring the first one up and say, look, you were struggling over here and over here, but now, a year later, you're actually saying you're feeling quite good about these things. And that can be really beneficial for a lot of patients. Could I have the next slide, please? Thank you. So there are quite a lot of challenges to working with someone with long-term health conditions. Having multiple health conditions is complicated, it's complex. It's what makes having a long-term condition complicated. It's a lifelong condition. So we have to help them with adapting to challenges in their life, learning more about their conditions and how they accept change. Building trust and maintaining engagement is sometimes a challenge, because though you're meeting somebody with the GP, until you've spent that time with them, you're just another person from the healthcare system. But we did have the benefit, we could spend a lot of time with patients. We had a lot of, like, not just in individual meetings, but over weeks and months, we could build up that trust. So although supporting behavior change can be a challenge, what you can't do on day one, you might be able to do in month 6. You could make that recommendation that makes them anxious, but you also know would be helpful and beneficial for them, and they're more likely to pick up that offer later on if it's coming from a trusted source. Sometimes there are system barriers that get in the way that we can't really do a lot about, like long waiting lists, limited local resources, eligibility restrictions, and digital exclusion. So Mary might want to get the Manjaro jab, for example, and she might have a few health conditions, but not enough to get that on the NHS. Progress can often seem slow and non-linear. Again, this is where the star comes back in. It can, again, highlight how far they've come. It's very, very good. It's an emotionally demanding role for the link workers. So we have to be careful of vicarious trauma. Next slide. I think I'm handing back to Sandra for this last slide.
Thanks, Thomas. So yeah, at Ways to Wellness, what we believe is, and we understand, is it can be really difficult to demonstrate impact to commissioners. We have a combination of both data, so the quantitative stuff, but the qualitative stuff is really, really useful as well, as Thomas has highlighted, the patient stories, how they're feeling. That's really important to be able to demonstrate. So the two things together we think are really important. We think in some ways the impact of social prescribing it really hasn't been demonstrated in terms of the impact on other sectors. So while we look at the NHS, actually the impact is on social services. It's DWP on the benefits bill. It's in education. It's in family support. It can be even in the criminal justice system, because this is people's whole life. So an intervention in one area can actually spread far and wide. However, that is actually really quite difficult to measure, and we haven't managed to do that yet, but it is something that we're working on. But what we do know is that collecting the data is really important, but you also need to know how to use that to be able to tell your story, but also be able to demonstrate what it is that you're doing, and that it isn't just about, from a commissioner's point of view, people feeling better. There is a saving somewhere within the system, be that time in terms of saving clinician time, because they're actually using their skills and their time to deal with clinical issues. And there is a really well qualified social prescriber there who is able to deal with all of the other areas. We're really passionate about being able to evidence the impact. And I know that through social media, I think from NASP and through ourselves, we're actually running a course for social prescribers and link workers. It's free, so feel free to book on it, which will tell you a little bit more about how you can use the data you've got. We're not suggesting you go out and do massive data collections. We're saying you will have data that is really valuable. We just need to maybe help guide you as to how you can use that in the best way. So please feel free to have a look at our website. There will be links. I'm sure I'll be supplying plenty of links to Monica afterwards to be sent out. And we're more than happy for anybody to contact us if there's anything you want to know about the projects that we run. Thank you, Monica.
Thank you so much to both of you. That was really practically useful, but also inspiring presentation. And I mean, the numbers that you shared right at the beginning, Sandra, definitely speak for themselves. But what it feels like you're doing through tools such as the Wellbeing Star is not just collecting the evidence, but actually establishing that narrative that surrounds those numbers in terms of the real difference that it's making to people's lives. And I think I speak from experience because I've used that Wellbeing Star tool as well, and it really is a fantastic enabling tool to support that conversation about getting to the root of that patient's or person's needs. So yeah, there's been a couple of questions that have come through. We'll come to those at the end. Please do keep them coming, and we'll put those to Thomas and Sandra and any of our other speakers at the end. But for now, I'm going to hand over to Bridget, who is a social prescribing link worker who's got a background in working in the arts for an inclusive theatre company for over 15 years, and then moved into the world of social prescribing in 2020 during the COVID lockdown, as it probably resonates with many of us when we started the role. Bridget has been a link worker with 2 primary care networks in Gloucestershire and currently holds the role of senior social prescriber for 7 Health PCN in Stroud and social prescriber for the Gloucestershire Long COVID Clinic, which is a position she's held since October 2023 and is going to be talking to us in a little bit more detail today. So yes, over to you, Bridget. Thank you.
Thanks, Monica. Yeah, so it's been really interesting hearing everything that's sort of has been talked about so far. So I'm going to talk more about the experience really of being a social prescriber for a service that focuses on one specific condition, and that being long COVID. So yes, if I could go on to the next slide, please. Thank you. The Post-COVID Assessment Service in Gloucestershire was originally established as an assessment and rehabilitation service in 2021. Social prescribing was introduced into the service in October 2023. That's when I joined them. And at that time, I was joining a team that included a GP, some specialist rehabilitation physiotherapists, occupational health, and clinical psychology. So we ran like that until March 2025, and then the service was slightly scaled down. And we continue now to offer a long COVID assessment and support service, but with a smaller team, which is a GP, myself as the social prescriber, and access to psychological therapist as well for long-term health conditions. So if I could go on to the next slide, please. So yeah, I was sort of thinking about, what did social prescribing add to the long COVID service, when it was introduced from 2023? And as all social prescribers on this call will know, one of the main things it offered was the opportunity to give patients to talk about the social, emotional, practical, and financial impacts of living with this condition. And whilst those sort of might come up in other conversations with other clinicians, we have that wonderful hour at a time to really focus on those things. How is long COVID impacting your life in all senses? So then the conversation supports them to explore ways of managing these impacts through personalised planning, but also through access to peer support, commissioned groups, local services, community hubs, and activities. And given the nature of long COVID, supported self-management is really central to living well with the condition. Social prescribing really provides that space for patients to reflect on what is it in my day-to-day that exacerbates symptoms, and what helps, what really helps, to reduce them. If people are having a good day, it's looking at, what happened in the days preceding that, and so it's getting people to really start to understand the condition and what's impacting their symptoms. So the conversations also enable individuals to develop plans and strategies, including how to adjust routines to integrate pacing, which is key to a sort of a condition that leads to sort of chronic fatigue symptoms. And it also creates the space to acknowledge both the progress and the setbacks, because people experience both of those when they have long COVID, and it's important to be able to listen and hear people when they're talking about the setbacks they've had, and then bring them back to, well, what's helped in the past. Remember when you made progress here, what enabled that, and to get them sort of support them back on the path. Could I have the next slide, please? So, whilst long COVID has wide-ranging impacts and it can look really different from person to person, there are common themes and common symptoms and shared experiences among those living with the condition. So, as a social prescriber, really focusing on this one condition and having spoken to sort of probably over 200 or more people with this, it's really deepened my understanding of these impacts. And that's enabled me to develop a resource database of really relevant both local and national programs, services, and peer support, but also a really comprehensive set of resources for patients. On a variety of aspects of the condition, which I was able to do drawing on the expertise of other members of the team, the occupational health and the physios, etc., and pull together a set of resources. Being part of the long COVID support team has enabled me as a social prescriber then to really hone that skill set around this one condition. And that's mainly been through learning from patient experiences, what they've been telling me, but also, again, drawing on expertise from other members of the team. So, one of the most significant areas of learning for me has really been how to work with uncertainty with a condition where there are very few definite answers. Um, and so it's really helped me to understand the value, even though we know this as social prescribers, but it's been really embedded for me, the value of listening and providing a space where people can be heard, validated, and understood. And often that's for the first time, because long COVID, like many other long-term health conditions, we might hear about them in the media or know somebody, with them, but we don't really know what it is to walk in those shoes and live with that experience. And so often people do feel quite misunderstood, whether it's in the workplace or amongst their friendship group or their family even. So that time, people comment time and time again on, what a relief it is to be properly understood and heard. And then we're able to really focus on what's most helpful for them going forwards. Next slide, please. So, yeah, social prescribing within an MDT, a multidisciplinary team. If we can move on to the next slide, this has been something that's been quite a significant difference for me working in this team, because as I say, I also work in primary care and have done so alongside my work in the long COVID team all the way through. So I'm able to sort of see the distinct differences. So social prescribers working in primary care don't always have access to MDT meetings or opportunities for that really close working with clinical colleagues. Whereas in the Gloucestershire Long COVID service, we've always held regular MDT meetings for patient discussions. Originally, in the original service, that was every week, and now it's more or less sort of monthly. So bringing that MDT, we're able to have good patient discussions with every member of the team, but bringing specifically that what's different is we're bringing that social prescribing perspective to the MDT, bringing that whole person approach to the thinking around each patient. So discussions encompass the practical, the social, and the wellbeing impacts alongside the clinical and psychological perspectives. We can move on to the next slide, please. Yeah, so as I was saying, bringing the social prescribing into an MDT, why is that helpful? Well, not only because it places social prescribing more centrally within patient care, and my experience in primary care, and I know it's sort of different for each person, but often in primary care, it can feel like it's a sort of adjunct to people's care. Whereas it's within this long COVID team, it's really brought it central into the patient care and really broadened the range of the support that we can offer patients. But the other thing it's done is it's really raised the awareness and the understanding of the social prescribing role amongst the other healthcare professionals. So that's supported better integration as well as that more holistic patient care. And that's been really I've really noticed that in primary care, often you're working across multiple surgeries, there's multiple clinicians and healthcare staff, and it's not possible always to speak to all of them and for each one of them to really work with us closely with a social prescriber and really understand that role. Whereas the team that I've worked with in the long COVID team have really had that chance to do that. And their feedback has been that it's opened their eyes to the importance of the role. So much so in the long COVID team that when I started, I might just, get a few referrals through to me from other members of the team to where I got to is that I speak with every patient that comes through the service now. So, no longer sort of, it's not an arm's length service. It's very central. So now every patient that's referred in will have an assessment with the GP in the long COVID service, and then they will have a social prescribing conversation with me. Will always be an hour to start with. And then we're able from that point to decide, does this person need, ongoing appointments? They might be an hour appointments or they might be half an hour appointments, depending on the need. And we just assess that over time. And I can work with those patients, as long as is needed to support them through whatever their goals are and what they're working towards. So it's been a really interesting learning curve for me as a social prescriber and really special. Thanks.
Thanks so much, Bridget. I'm almost certain that we haven't done that service justice in terms of all of the different elements of it that we could certainly learn from. I particularly really liked your reflections about how much you've learned from the people that you are speaking to through that service every day, and that has been part of your own sort of learning and development in that space. I think that is something for us to all take note of how we can actually be learning from the conversations that we're having every day, but also that the fact that it's been embedded within a specific pathway has been what has opened the door for those people to have that conversation beyond the clinical conversation, and it was really crucial that it was actually embedded within a pathway, a health pathway, in order to ensure that patients have that opportunity to have those conversations. So thank you so much. So we're going to move into the Q&A now. There's a couple that have come through, but if you have got any pending questions, please do put them in the Q&A chat. So if I can invite all of our speakers to turn their cameras back on. The first one is perhaps for Sandra and Thomas around whether there's an equivalent wellbeing staff for children and young people, and perhaps if not, if you're aware of any similar tools that might be useful in that space. Sandra?
Yes, there are. In fact, if you have a look at Triangle's website, you will see there is actually wellbeing staff for pretty much everything. We use them regularly. We have a number of programs that are on the go. So there's lots of different ones. So yes, there's definitely children's young people. There's a family one. Sometimes you might need to do a little bit of a mix and match if you're looking at a particular set of circumstances. But yeah, the answer is yes.
Great, thank you. So like I say, I've said in the chat, but I'll say it as well, that we will make sure that all of these links that we're talking about and the sort of further information on these resources and things are shared so that you can do some digging. And we'll talk internally about how we can make those resources a bit more visible to you as well. There's another question. I'm not sure who might want to take this one. Sandra, perhaps Jenny, in terms of what can be done to encourage secondary care clinics to employ more social prescribing link workers. So Ruth has said that link workers in primary care are still limited, and it would widen our reach as a workforce if hospital trusts acknowledge the lasting impact that we could have by working with those who attend hospital clinics. And obviously this is a real growing area, and particularly when we're having this conversation about long-term conditions, that is often where people might be coming into contact with the health service, and so to embed social prescribing within those services would be fantastic. But what more can we be doing to encourage secondary care clinics to engage with social prescribing? I don't know who wants to take that first. Sandra?
I'm happy to take that first. So we do actually run two programs which involve having a social prescriber in a secondary care setting. So Thomas actually leads one of the programs, which is based, it essentially works around our local hospital, and it's to do with people who are waiting for hip and knee surgery, and the social prescriber gets involved with them at the early part of their journey to help them become better prepared for surgery, because people who are better prepared for surgery tend to have far better outcomes and longer lasting outcomes. We also have another program that is running in our local children's hospital, which is working with families who have a child with a complex need. Now, in terms of getting link workers into secondary care, I think secondary care there are pockets within secondary care who really do see the value of a link worker and a social prescriber to help them with their patients. However, there is always the issue, isn't there, of who is best to deliver that social prescribing kind of role. Is that a role that should be within the NHS, be that primary care or secondary care, or is that a role that the voluntary sector could help deliver? And we have found both that, it can be delivered. It depends on the set of circumstances as to who would be best to provide that support. The issue when it's the voluntary care sector organisation who's providing the support is that the NHS is quite naturally risk averse. And I understand, I worked for a long time in the NHS and I understand why they need to be. But there is a little bit of a perception that the NHS can do all of this the best. And actually, that's not always the case. Sometimes the voluntary sector is better placed. So we have been working with secondary care, trying to get them to see the data, to see the impact of a social prescriber and the savings they can make. But some of it is about trying to find what is it that is going to make your commissioner, your secondary care provider tick. And it's not always the fact that they will make financial savings. Sometimes it is something like, the time released for clinicians to concentrate on clinical duties, which might reduce the waiting list, which might then impact the finances further down the line.
So similar principles to the approach that link workers are taking every day in terms of understanding what matters to those people and working in partnership with them to come up with the solution. So skills that we all already host as link workers. I'm going to put a question to everybody actually in terms of some learning that we can get from each of your different perspectives, and perhaps if you could just each say in the time that we've got left, perhaps one or two lines of this. But the question is about what does listening without assumption look like in practice in relation to the link worker conversation? Because we've talked so much today about how we don't want to define somebody by their condition, but actually have that what matters to you conversation. So I'm interested in terms of what your response is to that question that link workers might be able to take away to put into their practice. So perhaps if I just go down in the order that you are on the screen. So Bridget, what does listening without assumptions look like in practice for you?
I think it is exactly that. It is just listening. It's stopping any thinking around what might be what might we do next here, what might be a solution to this problem that this person's talking about. It is simply doing the listening. Because until and unless you do that, you don't get to I find I can't then get to a place where we can move on. It's through the fully understanding, hearing the person's experience in its full sense of what is it like for you at the moment living with long COVID. That might be a sort of question like or whatever it might be, and it's fully listening to that, and then being able to whether that's at the end of the hour in the next session or whatever, is then saying, so what do you think, what do you want to focus on, what do you what would help, or whatever it might be that you move on from. But it's validating that experience first of all. It's really hearing it, and it's reflecting back to the person so they know it's been heard and understood, and saying it in such a way that you're saying, is that right? This is what I'm hearing. Is that sound, is that correct? So they feel fully understood and heard.
Yeah, that is 100% being echoed in the chat. I like the fact that we're all sharing our own experiences of what that means. Jat, I'm interested to hear what that means to you. So what does listening without assumptions look like in practice to you from that patient person perspective?
I think I want to echo a lot of what Bridget has just said. But I would just say maybe just to ask questions as well, rather than just assuming that this must be the answer. So I think it was maybe Sandra or Bridget that touched upon when someone says, oh, we've had a really good day, but we also need to look at what's preceding that good day and not just to make an assumption, just to ask questions. So I think listening without assumption is just to keep asking questions, even though it might be that the answer is obvious to someone, but it may not be as obvious to us. And sometimes, you know how they say that you've always got the answer inside of you, but sometimes you don't know that until someone asks a question. So yeah, I would just say keep asking questions and not make those assumptions, and just see what the answers are from a service user perspective.
Great. I was a bit ambitious thinking that we'd be able to get to all the speakers. So sorry, we are going to have to leave it there. But thank you all so much for your contributions, your insight, the knowledge that you have shared with us today has been absolutely invaluable. So thank you so much. Thank you also to Govinda and Audrey, who have been working busily away in the background to make sure that this has run smoothly. And of course, thank you all for attending. We've got loads more resources on our website, including a page that is specifically got all of the links to the different evidence reviews, webinars that we've done before on long-term conditions, so do check that out if it's helpful, and yeah, we'll look forward to seeing you next time. Until then, thank you very much, and thanks again to all of our speakers today.